Hello, my name is Janine Evasick, and I am a psychology PhD student at National University, specializing in the impact of trauma on individuals and families. The focus of this presentation will be the stress and trauma resulting from a cancer diagnosis. From diagnosis through active treatment is the time period we will highlight, and with an eye toward setting patients and their families up for better outcomes into long-term survivorship. The impact of cancer does not end after treatment. Both emotionally and physically, the effects can be immense, with possible long-term debilitating consequences from cancer, as well as chronic and long-term complications due to cancer treatments. Although we will not cover the many challenges of long-term survivorship or end-of-life and death issues here, palliative therapy would be a whole other presentation. Fear of death is naturally a tremendous contributing factor of stress, as is being debilitated permanently or temporarily during cancer treatment. Treatment can completely disrupt normal family life and can lead to tremendous hardships on top of an already challenging battle with cancer. And these fears accompany any cancer diagnosis, regardless of type and stage of cancer, and regardless of the resources a patient and family may have at the start of treatment. So this presentation will take a look from a preventative viewpoint on reducing additional unnecessary stress during a time that is already a traumatic and highly vulnerable time for anyone battling cancer and their families. The target audience of this presentation is anyone whose life who has been impacted by cancer, and is especially geared toward healthcare professionals who serve cancer patients, survivors, and families. Cancer clinicians also suffer when their patients have poor outcomes and when they feel ineffective to improve their patients' quality of life. People diagnosed with cancer do not suffer alone, and the impacts of cancer treatment and into long-term survivorship are wide-reaching. There are many points to cover, so let's get started. Each person's initial response to learning they have cancer varies, as do the responses of family and other loved ones, and not everyone will go through all these phases or in the same order. Shock is likely, followed closely by fear, anxiety, and possibly denial. Many will at least temporarily experience some sort of a denial state, where their psyche cannot yet accept and grasp the reality of a cancer diagnosis. And this is normal and healthy. Time for understanding and acceptance should be considered the norm, and we will talk more about this later, using time as an evidence-based practice to help patients and family to better cope. Disassociation, this is common to see some patients or family members in a numb or withdrawn state, which can sometimes become a coping method for the rest of a patient's life. Depression goes along with feelings of helplessness and lack of control over one's life. Anger and hostility may be seen in the clinic and most likely by close family. This response is particularly common for survivors in remission once they realize they are permanently impaired in significant ways, either from cancer or chronic effects of treatment. Acknowledgement and acceptance are hopefully reached, but may not be possible depending on the stage of cancer. Death acceptance is challenging at any time, and some patients may be prevented or unable from achieving acceptance either by lack of understanding, such as parents not telling a child, for example, or by cognitive issues, the elderly or someone with mental illness, for example. For those with potentially many years to live, acceptance of being forever changed emotionally, if not physically, by their experience may never be achieved, and this includes caregivers as well. Final adjustment or post-traumatic growth will not be achieved by everyone, and we will be discussing ways to help facilitate adaptive responses later. There are some common coping responses seen in cancer patients which can vary by age. For example, pediatric and adolescent and young adult patients are more likely to use escapism from video games, and peer support is very important for adolescent and young adult patients and survivors compared to other age groups. Coping methods may be either adaptive or maladaptive depending on the individual and how they are used. Withdrawal, isolation, physical and emotional isolation from family and peers is common. The physical demands of treatment naturally contribute to social isolation, such as fatigue and nausea, time spent away for treatments. Body image issues can also create social constraints, such as hair loss or weight changes. The emotional distress created for a patient by perceived demands within family relationships in conjunction with their healthcare needs can also be exhausting. Patients may isolate themselves so as not to be a burden on loved ones, or because it is easier to not interact with those who don't understand. Withdrawing from normal social interaction typically results in sadness, clinical depression, anxiety, or post-traumatic stress disorder, PTSD. Seeking knowledge can be an adaptive response to the trauma of treatment and is shown to be a form of coping for many patients, providing them with a sense of control by then having choices, whether to prioritize goals with a shortened lifespan or to have choices for treatment and improving quality of life, or understand better how to manage their recovery. Indeed, a sense of control over well-being is the greatest adaptive response that is shown during cancer treatment. Regardless of life expectancy and physical impairments, greater hope and quality of life is associated with the knowledge for informed decision-making that prognostic understanding gives. A sense of control over well-being has been shown to be essential for caregiver quality of life as well. Conspiracies of silence, discomfort regarding death and dying issues are often at the heart of why cancer patients and family members avoid talking about subjects which are emotionally upsetting, and this discomfort extends to the oncologist as well, or because the oncologist does not want to break the conspiracy of silence occurring between a caregiver and patient. Unfortunately, avoiding end-of-life discussions is consistently associated with much poorer quality of life and outcomes for patients, caregivers, and family. Cancer patients do not suffer alone. Their illness affects the entire family, which then results in additional challenges for the patient. Many cancer patients express that the impact on family is more stressful than their treatment. The demands of cancer treatment alone may require frequent travel, living away from home temporarily, or moving permanently to a new area. Loss of employment for patients or caregivers creates additional upheaval and possible financial hardship, including loss of a home, needing to move in with family in order to make ends meet, or for help with child care or patient care, fear of basic needs being met. Children or siblings of a child with cancer may feel neglected if their parents' attention is diverted from caring for them. The behavioral responses of family members create continual challenges such as avoidance, coping, and symptoms of anxiety, depression, and post-traumatic stress. Marital strain creates additional instability for families. The changing roles within a family can be confusing, and this factor alone can cause great distress. For example, a man who is used to doing the more strenuous tasks around the house and the yard may now be an invalid. Or the reverse, a father may take on childcare roles that his wife did before her treatment. Changing leadership and managing household finances is another big challenge. Role reversals can be devastating to a marriage, and particularly when they continue long past treatment. So let's take a closer look at caregivers who are a pivotal point for families during cancer treatment and beyond. The person closest to a patient usually takes on the caregiver role, and the majority of family caregivers, 72%, are women. Caregivers may lose or leave a job when caregiving, possibly going without health insurance. Younger women caregivers are more likely to have child care burdens and may also be taking care of elderly patients, as well as working full-time. So the caregiver becomes the primary support of the patient, and the great problem this poses is that the health of cancer caregivers strongly impacts both short and long-term patient outcomes. But this is not a reciprocal relationship. Spousal caregivers typically put the needs of their patients above their own, and their patients often show quality of life scores that are higher than their caregivers. Spousal caregivers are documented as experiencing higher rates of distress equaling or exceeding that of their patient, with rates of PTSD twice as high for caregivers of adult transplant recipients than that of their patient, for example. When the needs of caregivers are not met, caregiver distress has been shown to increase with long-term survivorship and can lead to negative health outcomes long after the patient has died. Greater patient suffering at the end of life is also positively associated with caregivers' psychological distress, with significantly higher rates for suicide ideation in bereavement, as well as higher rates of PTSD, prolonged grief disorder, and associated depressive symptoms. Financial hardship for cancer patients and family is huge and is often not discussed during clinical conversations regarding prognostic outlooks. Yet this is a tremendous factor impacting health outcomes. When financial hardship hits when the patient or family is helpless to do anything about it, the patient can't work, the caregiver can't work, this adds considerable stress to an already vulnerable, horrific situation. Experts studying cancer burden and what is called financial toxicity continually emphasize financial stress as being one of the most important factors for patient and family quality of life, and that this should be included in prognostic conversations. Financial hardship is additionally strongly associated with higher rates of suicide ideation among cancer caregivers into bereavement. So now let's talk about how we can support individuals and families toward healing and family cohesion. Right from the start, there are two things that should be done: identify those most in need of support and establish good communication. There are many groups of people that have been identified as having a greater risk for poor outcomes during and after cancer treatment. Anyone with advanced cancer immediately qualifies for being highly vulnerable due to having a terminal illness. Persons with multiple comorbidities, including mental illnesses, those with English not their primary language, racial ethnic minorities, lower socioeconomic status, those with poor social support, single adults, recently separated or divorced. Women are particularly vulnerable. Those with caregivers that are unable to provide adequate support. The problem with using the categorical approach of identifying specific groups or populations as vulnerable, however, is because it's not giving us the true picture. It is best to look at each individual's level of severity for each risk factor, and then look at how those factors overlap with other at-risk factors. Those with a high overlap of vulnerabilities are at the greatest risk and will need the most support during treatment and beyond. Establishing effective clinician-patient communication from the start. Patient prognostic understanding is a key factor for achieving goal concordant care and improving patient and caregiver outcomes. It is often challenging, though, for oncologists to find the right balance between giving full disclosure of a patient's prognosis while helping them maintain optimism. Patient prognostic understanding is strongly associated with better goal concordant care, lower depression and anxiety in both patients and informal caregivers, drastically higher quality of life scores for patients and caregivers, lower caregiver burden and bereavement, less hospitalizations and less use of non-beneficial, aggressive, toxic, and costly end-of-life treatments, and potentially prolonged survival for the patient. So to ensure that patients and caregivers receive the information they need for clinical decision making, there are many prognostic communication models that have been shown good efficacy. Here are some of the most important considerations and methods we have learned to enhance patient prognostic understanding. First of all, the psychological distress of a cancer patient has been shown to impair their ability to process complex medical information, as well as interact with clinicians in ways which aid effective prognostic discussion. For example, the effects of stress and emotion on cognition can make a patient less prone to ask questions, and a physician who observes their patient distress may be less likely to offer prognostic information. A patient may also be relying on their caregiver to remember what is discussed, but a caregiver's ability to absorb and remember information may be impaired by cognitive issues, memory loss, especially in older couples that can be an issue. Depression, anxiety, sleep deprivation, and fatigue from caregiver duties is often a problem. So discussions about the pros and cons of treatment options with a focus on managing symptoms to improve day-to-day quality of life for both patients and their families is vital to engage patients and caregivers in productive prognostic conversations. Using simple words and phrases and rewording statements to give patients a clear prognostic outlook rather than focusing on numerical or medical details. For instance, scans show the cancer is growing, which means that treatment is not stopping the cancer. This means that your cancer is becoming worse and is now more serious. Encouraging questions, providing patients and caregivers with a prompt list of questions to help them know what to ask. For example, what is currently happening with my cancer? What are the chances of controlling my cancer? What can I expect in the future? Will this shorten my life? What are the pros and cons of this treatment? Should I be focusing on treatments that will make me feel better rather than ones that prolong my life? At the end of a clinical visit, a final check of patient understanding should be done to make sure they did absorb the most important facts, and then fill in any gaps in their understanding. Good communication between couples, both during and following cancer treatment, has been shown to drastically improve quality of life and outcomes for survivors and spousal caregivers. Effective communication between a cancer patient and their intimate partner may need to be facilitated by a couples counselor familiar with the challenges of cancer treatment in order to achieve better marital role adjustments. The challenge is that even couples good at communicating their emotions often forget to talk about the most important thing, how cancer is affecting their relationship. It is essential that couples recognize and accept the changes in their relationship in order to have a healthier quality of life together. Couples tend to talk about how to manage things around the house, but don't talk much about fears and worries, their emotions. Some of the greatest issues seen are losing control in a relationship, being physically dependent as an invalid, or no longer being in control of the finances or seen as the leader of the family. These control issues can tear a marriage apart following cancer treatment. If role reversals continue long past treatment, new self-identities will need to be formed for a healthy marriage. This is a type of grief, losing roles and old identities. Couples may need help reconciling and accepting that parts of themselves are gone, develop new identities, forge new relationships with their partner. Issues of sexuality, lack of physical intimacy, and physical changes in general are difficult for couples to talk about. Patients often hide their feelings about how their illness has changed them, and the spouse tries to protect them by hiding their own emotions and avoiding answering questions. It is best to be honest with children about cancer. There is no hiding from them when someone is ill or behaving differently, and it is more confusing and distressing to keep the truth from them. If they are not communicated with openly and honestly, they will be more worried by the snippets of information they overhear. Although they will certainly be fearful when hearing about a close family member having cancer, children are much better off if they can actively participate in maintaining family quality of life. Here are some good guidelines. Use words they will understand depending on age, and don't go into details unless the child is of an age or personality that wants more or needs more. The goal should be to truthfully explain enough for a child to understand and prepare for changes in their daily life. Make sure you set aside time to talk when you are calm and perhaps with each child individually. Some basic information they should know: type of cancer, what parts of the body are affected, types of treatment, the effects, how life will change during treatment, preparing them before a family member comes home, physical changes that are expected, such as vomiting, hair loss, looking tired, pale, weight changes. It's very important to explain that cancer is not contagious, explain that it is a serious illness, unlike colds, but may be curable depending on circumstances. Reassure them it's okay to be scared, angry, or anxious, and encourage them to come with any questions they may have during treatment. Calling a family meeting to discuss concerns is a good method. Gradual patient prognostic learning and acceptance over time has been shown as essential for most patients to make the psychological adjustments necessary to cope better during cancer treatment and into survivorship. Clinical recommendations based on empirical evidence suggest focusing on where a patient is at cognitively and emotionally at each stage of the disease trajectory. The idea is to partner with them, engage them in a working relationship throughout their cancer journey to help them make the psychological adjustments necessary for informed medical decision making, and all with the goal of orchestrating the best quality of life as possible for them and their family. Although conveying accurate prognostic information is essential, equally important is realizing that a patient maintaining unrealistic hopefulness is a normal part of the process to eventually accept their condition. Continually adapting to a patient's changing need for information is also important, as is viewing family and loved ones as an integral part of a patient's ability to adaptively cope. Those close to a patient should be included in the clinician-patient partnership as appropriate. So a patient or designated decision maker should not be rushed into medical decision making as much as possible. We now know from neuroscience that acute stress reduces working memory and cognitive function. This is why it is important to check for a patient's or caregiver's understanding after any important clinical discussions, and provide written format of what is discussed if possible to help them retain and gradually absorb the information. And that brings us to the end. I hope you've gained some valuable insights on how to improve quality of life for cancer patients and their family during treatment and beyond. Thanks for joining me. Take care.